to establish a system for monitoring, when we are going to establish a series of indicators or dashboards. And then once we have it, how are we going to use it? So this guidance is focusing a lot on, we're not talking about an IT system. We are talking about a support. It can be a technology, it can be a piece of paper, it can be a blackboard. We're talking about a support that is linked to people who use this support and who are going to be the ones to understand what is being what is the issue and what can be done about it, and processes on how the action or the corrections can take place. It is also a guidance that includes a lot of experience from countries, because it is by gathering the experience from countries, we are actually learning how things can be done, or what barriers there are, how things have done. Therefore, I'm putting here that this is an evolving guidance. It's an evolving guidance because of the experiences that we will be collecting. We will be learning from them, and we will be adapting the guidance, the indicators to the reality. The output is targeting many of you sitting here today. Is targeting governments, it is targeting implementing partners that work in country, and it is targeting software companies as well that develop the technologies that can be used for monitoring and that can be used for dashboards. Now let's look a little bit at some of the indicators, of this menu of indicators. When I say menu of indicators, it is really a la carte. It is really, you can choose. It is not a set menu. It is a menu where you get to choose. So one of the indicators that we're suggesting is the stockout rate. The stockout rate, considering it as number of events where we are missing demand. We see here in this data that we have put up, we see that there were particular issues in this reporting period 16. We have the reporting periods down there and the products in each of the colors, and then the number of incidents on the vertical axis. So in this reporting period 16, a lot of the products had stockout. So that comes clearly from this graph. Also, what can come clearly from this graph, this facility level graph, is that the BCG and the BCG diluents are constantly, very often on stockout. So why is it? So a facility manager who gets this data, what can they understand? What can they derive from it? So what is happening? What happened on that week 16, on reporting period 16, and what is happening with the BCG and the BCG diluents? Maybe it is, maybe the deliveries are not coming, maybe the deliveries are not on time, maybe there are other things. So then we can look at, okay, where the delivery is coming. And we can see here again that week 16, all the deliveries were late. So it essentially, that caused all of the stockouts that we saw before. So having these different indicators that are together helps understand what type of issues the facilities are facing and what could be the root causes for this. So the other issue that there could be, or that we note, is that with one in this graph, with 1 week where there is no delivery, they go on stockout. It probably means that the stock levels that they have are maybe very, very tight. So an indicator that we're proposing as well is stocked according to plan. That is looking at the stock levels versus the established levels of stock. In this data that we are visualizing here, we can see that this district is really overstocking for a long time, and then only towards the end of the replenishment period, they are getting into the normal range of stocks. So what can be the issues? It can be issues with, for instance, the orders, that they are ordering too much or that they are forecasting too much. So one of the indicators that we're proposing is also the forecasted demand ratio, where we are looking at how much, so the actual demand, the actual usage compared to the forecasted usage. This district here could actually be the gray line below, which is actually using less than they are forecasting. We also see here the red line, or orange in this, in this picture, that is using much more than they are forecasting. So what could it be? It could be that they are having too much wastage. So looking at the closed vial wastage is also one of the primary indicators that we are proposing. Then as well, so if there are closed vial wastage issues, it could be due to the temperature in the cold chain equipment not actually working. So there is an indicator on temperature alarm rate, which is the proxy for the quality of the vaccine, for the safety of the vaccine, and the potency of the vaccine. It just looks at the number of alarms, so in a very, this is a simple indicator. You can see in a more so once the system has learned a little bit, once we have the different facilities, the different districts reporting on these indicators that we choose, we can make them a little bit more detailed. For instance, this one could be a split between the heat cost alarms or the cold cost alarms. The indicators can change. This is the concept of an evolving thing. The indicators change as our system and our reality changes as well. Another indicator, of course, is the cold chain equipment functioning. So very simple: is it functioning? Is it not functioning? And for a period of time. So those are the primary indicators that we are proposing. The idea, as you see with the menu, is this of a choice. A country knows where is it that they are at, where is it that they are having issues. Therefore, which indicator do they want to have? Do they want to have an indicator on cold chain equipment functioning or not functioning, or do they want to have an indicator on stockout rates? They also know what is their capability. Can they collect this data? Can they report on this data upwards and back and downwards again? So a country can really choose of these indicators and then work towards continuous improvement. These indicators can be put together, as I very briefly showed, to explain a situation, to give a little bit more of a comprehensive picture of what may be happening in a given segment of the supply chain. So, and as we learn more, then more indicators can be added. I cannot imagine that we are in a situation where the countries in which we are working can immediately start with the 7 indicators. No, let's start with 1 indicator. Let's start with a simple 1 indicator that we may record maybe via phone calls and record it on a piece of paper, or record it on an Excel and give it back when we are giving the deliveries of the vaccine. But make it simple, but let us start. Let us start, because what we have seen these days is that as soon as we are getting some information, as soon as we have a little bit of insight on what is happening in our supply chain, we are able to start making some changes. We are able to start making some improvements. So let us start, even if it is with something very little. Of course, we are not disregarding the challenges that we will find, and some of the challenges are going to be around the understanding and the use of the data. Will there be a capacity in the different levels of the supply chain to understand and use this data? This is related to the presentations we have seen this morning about the capacity building of the health workers and the staff in the health supply chain. Also, there is how are we going to be able to support this initial implementation? So if those countries among you or among others that may be thinking, okay, this is something that I would like to work on, can UNICEF, can WHO, can the country itself really support this implementation, and how are can we finance it as well via the donors? Another challenge that we are seeing is the need that there are many things happening in the country, many entry points, many actors in the country as well. So how are we aligning this? That is where we are hoping that with the implementing partners among you that are working in countries, if you see the value of this, you can take actually on some of the indicators and start aligning the work as well. So I mentioned earlier on that what we are having, the menu of indicators and the guidance, is draft. Therefore, we are now collecting country experiences to really make sure that that we can validate it, and continue the conversations with partners and countries to make sure that everything is valid. And we are also starting the external review of all of this. So if you're interested in reviewing, we have a survey that you're very welcome to. It will be published, it is being published in TechNet, so you're very welcome to respond to this survey, which is only going to give us feedback to this menu of indicators and to this draft guidance to make sure that it is as inclusive as possible. So let us start. It is just with a very small thing we can start monitoring and understanding what is happening in our immunization supply chain. If you are interested in contacting WHO and UNICEF to help you go through your thoughts, we are available. We can also, you can also respond to our survey, and you can provide input to the body of documents that we have generated. Thank you. And we have a leaflet that I said I would have here, but I don't have it. But it's, and it is outside at the tables there. Yes, thank you, Masari. And we are having a breakout session, and thank you, Jan, he's my secretary. And we are having a breakout session this afternoon as well, where we will be able to discuss this with a little bit more detail, so everyone is welcome. Thank you now.
Thank you, Gemma. One more time, a little applause for Gemma. And now I'd like to turn it over to Brian to take us away with the country examples. Brian.
And actually, before we get started, we're missing one of our panelists up here. So I wonder if anybody has seen Dr. Kapuria around, if he might be out in the main area. So saw him earlier today, but okay. All right. Thank you, Patrick.
Patrick's on it.
Very good. So yes, thank you, Gemma. It's actually great to see this level of collaboration and emerging global guidance to creating dashboards that really do matter. There we go. Excellent. Yay. As we add more systems and tools, it seems that we are collecting more and more indicators and tons of data, and yet it seems that we're struggling to find that tidbit of information that really helps us manage the flow and supply of health commodities. On Monday, we saw a video describing a tale of two mothers, and I wonder if we should also have a video of two healthcare workers and two nurses in a clinic to sort of show their lives before and after this global guidance comes out. It seems that throughout this week, we've been discussing some fabulous examples of how several countries are reducing the barriers that have prevented each and every child from being vaccinated. And now I have the pleasure of introducing three more country innovations and how they've utilized data and logistics management information systems, or LMISs, to increase the availability, potency, and efficiency of the immunization supply chain. So initially we have Wasif Raza Mirza, who will describe how Pakistan has networked the information systems for vaccine logistics with the country's vLMIS. And Wasif has a deep understanding of the information and communication technology aspects that are required to make an LMIS successful, with many, many years of experience in the software industry, working with data as a chief technology officer in the commercial sector before joining John Snow Incorporated in 2012. So Wasif, I'll let you take it off here to start off.
Good morning, ladies and gentlemen.
Wasif, pull the microphone down towards you. Yeah, there you go.
Now it's clear?
Better.
Okay. Basically, today I am presenting vLMIS, and our role in vLMIS is to strengthen, to empower government of Pakistan for the routine immunization. And which is evident from this slide, that it is present on the Gov domain and already hosted in the government sector. Pakistan is a big country in terms of the population. It's 196 million people with more than 50 million live births per year. And there are 4 provinces and 4 administrative areas with 143 districts. So when we start the vLMIS, there were significant challenges in the collection, use, and management of the logistic data in paper-based logistic and supply chain management. Generally, vaccine commodity operates with varying distribution system and distribution levels from federal to the districts and sub-districts. There was automated system at the national level, but there was no system at the provincial and the sub-district level, district and sub-district level. And the FIFO was one of the main challenge in inventory management. And there was also a limited cold chain asset data availability in that time when UNICEF had just started collecting the data of the cold chain in the CCEM. And there was no linkage of capacity with the current inventory. Likewise, at the consumption side, there was inaccurate immunization data because the at that year immunization program was claiming that it was 95%, but when a survey was told, depicting that it was only 54%. And likewise, the wastages figures were different, and there was no dependable basis of forecasting or procurement. There was UNICEF was doing that based on their own data or the collected data from the. Actually, it was due to the total paper-based data and total paper-based data, and there was so many human capacity issues. Same is at the cold chain inventory data. There was a fragmented antigen storage in a single cold rooms, and there was no real-time linkage with the capacity. In nutshell, there was no evidence-based decision making, and likewise there were issues of the HR accountability and at the various levels of EPI program. How vLMIS started? vLMIS started with it was a measles outbreak in 2012 when government of Pakistan requested USAID to start to include the vaccine products in the current LMIS, and the project has done many consultative meetings with the partners and the government of Pakistan to how to include the products. Initially, the mandate was the logistics, but it was later on the program indicators was also included in this information system. LMIS was actually started in 2011 with the contraceptive health products, but later on tuberculosis products and then vaccine products were included. And it's not this is a busy slide, but just to give you a gist that it is basically, the LMIS was basically from the Bangladesh, and it was based on a Bangladesh model, and later on it's enhanced with the country context with the contraceptive, and then it's further enhanced towards tuberculosis and vaccine. Now vLMIS in the process of including demographic and service indicators. So if you see the current LMIS data entry form, it contains all programmatic indicators. vLMIS is basically a comprehensive software in terms that there are so many softwares were present in that time when it was started, that at one end it was VSSM, at the other end UNICEF was collecting the data on the CCEM2, and there was inventory management totally on the paper based in the registers. But then vLMIS was developed with the concept that it can integrate all systems capability into one web-based system. So if you want to visit, you can visit from v.lmis.gov.pk. And the last month it was available through guest and username and guest password, but now the government is providing the different users for accessing the data. Actually, vLMIS has 4 data streams. If you can see that at one end it's doing inventory management from federal. There are 6 levels in Pakistan: federal, provincial, divisional, districts, tehsils, and union council. And the vaccination occurs at the union council level, while the manufacturers are supplying vaccine at the federal level. So at the vaccine transported from federal level up to the union council at 5 stores, and 6 is the vaccination level. So that the way vLMIS covers that part, that inventory management, and then when the inventory reached at the vaccination point, then the reporting started upwards, and that's called consumption reporting module. And the next is the CCM, which is basically cold chain equipment management. It has the major features of the CCM2 softwares by the path, and consumption reporting on the basis of special immunizations activities are also included this vLMIS. At different levels, there are different modules are involved. For example, at federal API and the provincial level, there is the inventory management, GS1 barcoding, pipeline shipment, cold chain management, and campaign management. While at the district level, inventory management is present, but barcoding is present, but for the few districts. And at the UC level, there is only consumption reporting. And here at the UC level, you can see how the wastages are calculated from the given data from the vaccinators. Normally, in our data collection tool, there is no indicator like wastage. It is calculated through the different other indicators like vaccination versus open vials. vLMIS is very simple in terms that it is getting the data. The data is uploaded at the monthly vaccination report through the vaccinators at the cluster level, and the inventory is also pushing the data at different levels, and then users are using this vLMIS data for informed decision making. And how powerful is this data is basic. With the vLMIS, you can visualize the national picture at the glance. Right now, there are 83 districts are reporting, 54 districts are completely reporting, and rest of 28 districts are just started reporting on vLMIS in the Sindh province. It is the intervention is not just a software. There is a complete software development life cycle from designing to the implementation, and then there was a jointly supportive supervision was provided. More than 200 API workers were trained at the different levels, including the on the job training. And the project had also provided computer printer and UPS and internet dongles at the different levels. And the vLMIS is a powerful tool in a term that you can see at the union. You can see wastages at the union council. If you can see in this slide, there is a line which is showing that, a red line which is showing that this is the allowable wastage of BCG. But there are, and the blue bars are basically consumption. So so the policymaker can easily detect where we have more wastages. Likewise, reporting rates and the reporting rate accountability through different different reports where we can track easily that which vaccinator has not reported yet. And likewise, there are in different reports which are showing stock outs, under stocks, etc. And there is a very interesting slide where you can see the consumption, and the line, the yellow line, is showing the target, which is a denominator. And you can see that there are many, a big consumption, the consumption is more than the target, where you can see that how this consumption can be happen if there is no vaccine. And the interesting fact is that if maybe they have less wastage, they can use the vaccine for the consumption, but how they can know the exact target and exact vaccination. So these are the questions for the policy makers. Stock, it also shows stock position of district stores through reports and graphs. And it also shows the cold chain capacity. The blue one is the net capacity, usable capacity in a cold room, and the green one is how much being used. It is the picture of the national EPI the 3 days back. And this is the antigen-wise distribution, where you can see in a cold room which antigen is stored with other. You can see that there are cold room where 2 or 3 antigens are stored, and there is a very distribution which can be. This figure was very bad in 20-30 days ago, but after this dashboard, it becomes visible to the manager, and they have shifted the vaccine and make the picture better. Likewise, with vLMIS, you can see the cold chain capacity and then vaccine storage with respect to types. And likewise, we have started barcoding pilot and with measles and the TT vaccines. And you can see that we have adopted a process where we use different type of we use barcode scanner, which passively get the data and then upload to the vLMIS. The lesson we have learned that there are 3-4 levels, packaging level, which are required, which is defined in the VPAC, but it is not the case in the different vaccine, because it has more than the prescribed levels, and without the barcodes at different levels. And serialization problem, quality of barcode problem, mixed batch and loose products problem. And with this pilot, we also simplify our scanner application too. More of the, we are doing a session after it in the Innovation Cafe, where I will discuss more about the barcode pilot. And lastly, if for vLMIS, we learned that there should be a more government ownership and required for implementation. And this is an open source software, and if the other country want to implement it, then it's open source, and anybody can extend as per their country needs. And last thing for the industry, that industry should respond to the barcoding requirement of all antigens, because the barcode is the only way to ensure that the right batch is reaching at the right facility. This was 2 slides. Thank you.
Thank you, Wasef. It's great to be able to start to see some of the dashboards on your slides that are already reflected in Gemma's earlier presentation. And now we have Bhrigu Kapuria, who will present on how end users in India were engaged through a mobile LMIS to increase data visibility and use. Dr. Kapuria has been working as the vaccine logistics and cold chain lead with the Public Health Foundation of India, with previous roles, I believe, as a technical officer with the World Health Organization and also the National AIDS Control Organization. So take it away.
Thank you. Good morning to everyone, and thank you for this opportunity to present. First, let me apologize for stepping on the podium a little late because of some personal emergency to attend. What I'll do is, I will take you through the work that we have been doing in vaccine logistics, but focusing on the topic of how to do data management using that. We'll be having a separate session in the afternoon talking about how we deployed the technology and all those parts, but at this point of time, how we use it, data available. So what we deployed was called as the Electronic Vaccine Intelligence Network. This was deployed in 2 districts of Uttar Pradesh. To just give you a quick background, you know India is large, and we do one of the largest immunization programs in the world. The annual target for newborns is around 26 million newborn children and 30 million pregnant women every year for primary vaccination. I don't talk about boosters. And we manage this entire system of cold chain and vaccine logistics through 27,000 around cold chain points. Now, I have around 90 to 95% of points sub-district level. When I say sub-district, I mean villages, towns, small areas, and all those. Giving you a flavor of what India expands, the annual expenditure is $718 million US annually on the immunization program by India. And one critical factor is 90% of it comes from Government of India funding. The remaining fundings get distributed like this, and this is the actual figures of 2012. So within this bigger frame of quantity and the amount of money goes in, we manage the vaccine through a 5-tier logistics system. But the current system in the country is very variable. It depends upon a district, how the district is managing it. So it varies from a district to a district to a state to state. And so you will see various pictures, what is happening. One major reason of this variable management is lack of visibility. And lack of visibility contributes because a majority of my, as well as yours, cold chain points are located at peripheral levels. So you don't have a visibility of what is happening at those points. And then because of that lack of visibility, you don't have visibility in change. We call this effect as a coal mine effect. And to understand this better, ITSU took in a study called as a deep dive exercise to look in what is the end-to-end challenge between vaccines from the suppliers to the last consumption. Based on that study, we found various things, but the 3 major identified root factors were lack of stock visibility, lack of human resource, and poor record keeping and reporting practices. Now, if you look into these challenges, the challenges of human resource, challenges of recording, challenges of supply chain, and challenges of infrastructure, I don't see India to be an exclusive country. Every country, every low and middle income countries face these same problems. And my next slide also says these are our challenges. You also face the same challenges. We have 36 states who manage healthcare, and health is a state subject. So whether you want to implement it, it's the state who decides when to implement it, how to implement it, what time, what flavor. So it has then again, within the country, it's not one. The entire country is not one. So you can't take, so you have good performing states, you have poor performing states, you have average performing states. So everyone is at different levels. And within that, I don't want to cry like a crying baby, but these are hard fact realities. We have geographical challenges, areas which are plains but are highly populated. You don't have roads to access to, and areas where hilly terrain, only 3 families live at one hill and the other 15 families live different. So what do? Do you want to reach those living at high density population? Do you leave people living on the hills? So and the final thing is, one rigid structure doesn't fit in. You need to be flexible. Flexibility is the mantra. So things what you adapt should be adaptable both at the hilly terrain as well as in the deserts. So these are all situations which brought in us to think. And thinking about that, we designed a system called Electronic Vaccine Intelligence Network, which had 3 components, and now these 3 words are very commonly familiar with everyone. We talk about human resources, we talk about streamlining processes, and we talk about bringing in products, which includes technology and other devices. So the product design, the EVN design, if you talk about, it consists of one technology. Remember, technology is only one component of it. The other is human resource. The third is capacity building. The fourth is supervision. And the fifth is temperature monitoring. So what we said was, if you bring all these components together, so this is a dynamic model. You practice the same model, you call it whatever. If you bring these components together, you might be able to manage your logistics better. Again, one very critical factor was bringing in appropriate technology. So bringing in computer-based, internet-based technologies doesn't suit me, and maybe not doesn't suit you, because at my peripheral health facilities, either there is no computer, even if there is a computer, I don't have electricity or internet connection, or my cold chain handler who's handling these vaccines doesn't have that capacity to manage a computer-based system. But what is common? Everyone is carrying a mobile phone in his pocket. Everyone knows how to use a mobile. Okay, the use is limited. Somebody uses it only for calling, somebody uses it for doing the entire office work, but everyone uses a mobile. So we said, okay, this could be an approach where you can use and reduce all your dependency points of data. So we brought in appropriate technology where computers can be used, you can use your computers, where mobile can be used, use mobiles. Again, my cold chain handlers don't know how to use a smartphone. So touchscreen was a big thing. So let's come down to basics. Let's come down to Java-based handset phones. So we brought that into practice. Now coming into, so that's the implementation part of it. Now I come to the data. One big important part is data. What is required, what is collected, and what is used? I think we all need to answer this question again and again, because sometimes we all go into a data greediness of, if I'm collecting data, let me collect this also, let me collect this also, let me collect this also. And a large component of that gets dumped into some file which we have never used. So we also thought about this component. My previous boss used to say one very clear line, and I've phrased him and said, actionable data is meaningful data. Rest all is waste of efforts. So if you have a data which you can't act upon, then it's no point collecting that data. And what is an actionable data? An actionable data is very different from levels to level. For a cold chain handler, the actionable data is, do I have adequate stocks? She just wants to know, do I have adequate stocks, and when should I reorder? For a district level, is anyone going out of stocks? So these are just some flavors that I'm bringing out. Is there anybody who's not reporting? Is there anybody who's consuming too much or who's wasting too much? So these are the factors these are actionable points at the district level. When you talk about a state level, the state level has a different thing. How are my district performing? Do I have adequate buffers? Which is the vaccine that I'm going to run out in stock? So he has a different data requirement. So you need to customize your data. And the most important point is, within the system, people have limited capacity and, most importantly, limited time to infer to your raw data. So if you give them a dump of data, you don't expect them to read that, find out, filter out, and so your data should speak. I give you only two small examples. One is this example. So this example is a green, if you see two green bars, these are, at this place, sessions happen on a Wednesday and Saturday. So if you see the green is Wednesday and Saturday session. The cross represents somebody has reported or not reported. So this simple line shows you who has reported, who has not reported, who has reported on time. A clear actionable point. Where don't you find a cross? That means that point has not reported. People who have reported late, you know who are late performers. You can target your action upon. The second data is, this is my data of one big consumption, and this is what we give. And now the problem is, with this kind of data, I don't know what to look upon. So what we said is focus areas. If you see within this entire data system, there are orange boxes which represent that somebody has not, so the diluent and the vaccine are not matching. Okay, the red says somebody has overstocked, and the pink says overstocked, and the red says out of stock. So if you want to look into the data, what are my action points? These are the 5 points I need to act. If I want to go deep down, you have data available, but the actions that you require out of your data should come out very clearly. What do we find out of that? We found that using simple, limited, quality-based data, the data adoption rate, the access rate is 90%. The completeness rate, so access happens, but what the data complete? So the data complete also range around 87%. This is an assessment that I'm talking about. This is not, the data timeliness is 87%, and the data accuracy, when we went and see the data on the system, on the registers, and in the ILRs and defreezers, how much do they match? It's matched 82%. So, and the best part was, in this entire system was, in 6 months of time, you practically vanished stockouts. So there were no more stockouts happening. And that's the end result, because what I feel is, with this entire work that we do upon, it is to ensure that vaccines are available for that child to be immunized. So if I prevent stockouts, I'm ensuring that vaccines are reaching to the children. So in 6 months of time, stock counts practically eliminated. Thank you.
Thank you. That last slide around the stockout trend is phenomenal. That's a wonderful use of data. And I also like the quote of actionable data is meaningful data. All the rest is waste of efforts. We're all sort of very concerned about vaccine vial waste, and yet we seldom measure how much data collection waste we probably have. So Chathura Edirisuriya will now describe how they responded to problems identified during a 2012 EVM assessment with a web-based immunization information system for Sri Lanka. With over 2 decades as a medical officer, Dr. Edirisuriya has joined the epidemiological unit with the Ministry of Health in Sri Lanka in 2009. And he's been the project manager for this web-based IIS with a special interest on advancing the use of GIS, Geographic Information Systems, and the visualization of data. So please.
Thank you. Thank you. Good morning to you all. Today I'm going to present the inventory module of the web-based immunization information system developed by the epidemiology unit of the Ministry of Health, Sri Lanka. Let me give you some background information. EPI Sri Lanka is a strong performer in the region as well as globally. EPI is the main provider of immunization services in the country. However, private sector involvement in immunization is increasing and expanding, particularly in larger cities. Present immunization management information system is a paper-based one. Current e-government and e-health policies of Sri Lanka for public services led the development of WEBIIS. What is WEBIIS? WEBIIS is a web-based comprehensive software solution for online immunization data management, which covers birth registration, immunization tracking, inventory management, report generation. This software developed from the scratch using open source software. Why we developed it? With the introduction of National Immunization Policy in 2014, Sri Lanka is looking forward to implement mandatory immunization throughout the country. To support this process, a database on immunization status of children a database on immunization status of children becomes essential for future reference. Primarily, WEBIIS cater for this requirement. In addition, the National Immunization Policy gives the framework to reach the private sector for data collection. WEBIIS will facilitate this process because private sector is more geared to use IT solutions rather than time-consuming paper-based systems. In year 2012, EVM assessment was conducted in Sri Lanka. Few of the recommendations that came out were to use computer-based inventory system, record VVM status at issuing and receiving points, wastage calculation at all levels, dial 1 registration, quantified minimum and maximum limits for each vaccine. These are the summary of EVM assessment done in 2012 in Sri Lanka. I would like to draw your attention to the E6, that is stock management area, where we have performed less than the expected levels. This is the same information in a another graphical format. So with the findings of EVM assessment, we have made some feasible changes in the WEBIIS. Those were the VVM status recording at all levels and dial 1 registration. And we are currently working on wastage calculation, and setting the minimum and maximum levels for each vaccine at each warehouse level. We have started piloting the developed system in 3 levels of warehouse we are operating. So let me take you to some highlights of the system. This is our home page, and we have categorized the functionalities of the WEBIIS into menus, and both sides you have notification areas, and at the center we have a notice board. This is a picture of master menu. WEBIIS uses master menu to define or feed the foundational data of the system. Therefore, inventory submenu of the master menu uses to manage the groundwork of the inventory module. Using the master menu, new vaccine batches are defined within the system. It also helps to define or attach relevant diluents. This is a general inventory menu. It gives the ability to manipulate the warehouse comprehensively. We can create a warehouse in different levels, and if you want to do the stock adjustment, we can do, and likewise these functions can be done. Within the system, we can define the warehouse in each health facility. 3 main areas of information are needed to create a warehouse. First, warehouse identification details. Second, temperature criteria. Third, storable vaccine within the warehouse. Any vaccine that is not meeting the temperature and storable criteria won't be able to add to the warehouse. When we are adding a vaccine stock to the system at the central store, vVM status can be marked. Then each issuing and receiving points, vVM status can be modified or updated. So you can see the batch vVM at the middle of the here. This is the initial vVM, and here in red box, when we are the vVM status at the issuing point. So then we come into the reports. This is a stock position report of a warehouse. It gives the warehouse and the vaccine available, its batches, and the balance available, expiry dates, and the vVM status, and the breakdown of doses according to the vVM. This is a monthly vaccine distribution report. This report also can be generated by the WEBIIS system. Actual vaccine used for immunization can be tracked and generated a report if service delivery point uses the online tracking module of the WEBIIS. Okay, let me tell you some problems we have encountered and how we manage those situations. First, we have ever-changing requirements by the users or the industry. So, to tackle that problem, we set the business requirement specification, and we use web-based modular approach. And the second one, underdeveloped IT logistics in periphery of the country. To tackle that one, we are now gradually providing the equipment and the internet services to those places where those facilities are required. And third one, the low IT literacy among field staff and high turnover of IT development team. So we have to continuously train our ground level staff, as well as we have to put the technical staff to the development team. And we have faced a malware attack, it's a random attack. So now we have hosted our server in a reputed ISP with firewall protection, as well as we have assessed the software by Sri Lankan Computer Emergency Response Team for security loopholes. And we have implemented the recommended guides. Okay, way forward. Now we are planning to full implementation of the inventory module island-wide by 2016. By doing so, effective vaccine management, avoiding any supply or quality failures, minimizing wastage of vaccines, efficient monitoring of vaccine supply chain at all levels. WEBIIS is a teamwork, so I would like to mention these names here. UNICEF has given us financial support, and Dr. Papa Parivartana, Dr. Sudat Piris, and Dr. Anand Amarsinha, my senior colleagues, for their technical and administrative support. Dr. Asantha, Dr. Manjula, and Dr. Tushanti. They have given us many technical input, as well as they have helped in training activities. WEBIIS Limited for undertaking this project, and Sri Lanka Mobitel Limited for providing mobile internet services, and all health staff who are using the system providing useful feedback for further development of the system. Thank you.
Yes, thank you very much. And I liked your comment around the hosting of the web-based systems as countries move to doing a similar piece with their logistics management systems. I think they can probably learn a lot more from your experiences. We've now seen 3 different LMIS systems here in the region that have documented a similar set of user requirements, and yet they've also deployed a similar set of functionality, although on different technologies. And I'll ask Jan Grevendonk from the World Health Organization to lead the panel in a set of questions and answers on the use of data, evidence of their initial success, and then how systems are being scaled and sustained. I've personally enjoyed working with Jan over these past few years. He has a refreshing perspective on the appropriate use of information systems, and he continues to challenge me and others on being smarter about how we use information and communication technologies. So please, Jan, ask away.
Thank you, Brian. So I'll kick this off by just a few questions to the panelists, and then I'll open it up to the public. Also, just to say that people on the TechNet community can also kind of listen in to all these talks, and you're also welcome to submit questions. Actually, I have a tablet here in front of me, and I can look at your questions and also address those. So first of all, thanks for all the great presentations. They happen to be all of the same subcontinent, but there was a lot of variety anyway. In all the presentations, there's a lot of achievement, but I also wanted to focus a little bit on the challenges that you must have met, because I think challenges are always there. Everybody who worked with IT and data knows that it's not that easy. It's always longer than you think. It's always more costly. There's always more opinions than you thought. And I wondered how you kind of cope with those challenges. And let me start with Bhrigu. And the question is basically, so now you're achieving this visibility that you say will change the system, and actually started to change the system. But you also mentioned HR challenges and people challenges. So what I wanted to know is, like, given visibility is one thing, getting people to act on the data, or even willing to accept that visibility is another thing. So do you have any strategies for that? So for strengthening the HR capacity, or actually like the communication with people that are end users of the system?
Sure. So thank you, and this is one of the pertinent questions that comes in, because generating data is one part, using the data is another part, and I think having a human resource is very critical part of that. So if you see into the entire system of EVI, and a special dedicated vaccine and logistics cold chain manager has been created, to manage that, to provide support to the district, who has the overall responsibility to look in data. The other important component is, so this is a kind of a management structure, but beyond that, how do you ensure that people generate the data and use the data? The only answer to that is if that data is useful to them. So if I submit something and if I get something back in return, not financial gains or something, but if that data creates something meaningful out of, for me, I enjoy doing that, I ensure doing that. And that is what we have created. So when you submit your data, you get a feedback of what is happening, you are updated, you know what to, and your supervisors also know that you are at this point of time. So if you are going stock out, it doesn't come back to you because you have not informed on time or you didn't ask for on time. Now everyone knows that. Okay, so that responsibility sharing kind has ensured that people respond, so that it doesn't ends upon me saying that I was the reason why this happened, and so that feedback loop has ensured people using it more and more on timely. So I complete my work, I ensure that it goes on time. I have done so that kind of environment has helped data use.
Thank you very much. So it's a combination a bit of bottom-up demand for data and top-down management also.
Yes, yes.
So then that's actually a good lead into the next question that I could ask Wasif. And the question here specifically for you, and maybe even more so than India, you have a very decentralized situation. So I know there's at this point, no centralized EPI leadership in Pakistan, so it's a province level responsibility only. So my question is, without that lack of really central leadership, is that a challenge for you then to make sure that you have some kind of uniform or common management system across all these provinces, if everybody have their different requirements and asks from you?
Thank you, Jan. Yes, actually, I will give you an example of province which is when we scaled up the vLMIS in the province, and they asked us for create a detailed data entry form at the vaccinator level, while in Punjab they are only interested in the logistics indicator, and the program indicators they are collecting themselves. So different provinces have different policies, but what I have seen in the past, that whenever a province started with a new step, the next month or after a quarter, the second province asks for the same. So yeah, it is a little challenge that we have to convince different provinces on a centralized approach, but we have a mechanism like vaccine logistics and management committees and other forums where we requested different managers, EPI managers, to come and see the idea floated by one province. So somehow it is managed right now, but maybe in future we have more collaborative effort to reach up a single set of requirements and single set of dashboards. Thank you.
Thank you very much. That's helpful. That also reminds me of the work that PATH is doing on the common requirements, and we indeed thought at that time also, because I was at PATH before I joined WHO, that having these common requirements and a formalized way of structuring them and writing that down would really help not only countries but also collaboration between countries to share kind of a statement of what they need from systems. So maybe my next question for Chathura from Sri Lanka. So actually it's the second time that the system is presented at TechNet. 1 year ago, your colleague Dr. Sudat Peresh, do I say that right? Yes. So he was also here, or he was in Senegal rather, and he presented the registry part of the system, and now you add a logistics part. So I was just wondering, I know from experience that this is actually a very ambitious and difficult thing to do. Dr. Sudat also mentioned that the project took already more time and was more complex than they ever imagined. And I wonder if you have something more to say about that in terms of the timeline of now scaling this up. So you mentioned implementation nationwide by 2016 in the island, but I think the experience from the registry also shows that it's probably going always a little bit slower than you think. So do you have any lessons learned about that?
Yeah. We have difficulties in rolling out the system. Actually, the most difficult part created due to this inventory system. We have incorporated it up to the clinic levels, so it is a closed loop one. So every clinic has to be run according to the guidelines. If somebody deviates from it, we can't run the system properly. So now we are trying to open with the system. That means we are trying to break up the closed system and run from central level to the regional level and to the divisional level. So we have one central store, 26 regional stores, and the 337 divisional levels. So already computers and the internet facilities are there. So if we break up from that point, we can easily implement the logistics system there. For the registration part, actually Sri Lanka has about 603 hospitals where deliveries can be done. But most of the deliveries, about 90 to 95% are occurring in 70 hospitals. So the registration part, now we are planning to implement in those 70 hospitals, probably within this year. Up to now, we have implemented in 44 hospitals. So by that way, we are trying to roll out the system as quickly as possible.
So lesson learned is you kind of try to simplify things and actually make it a little more flexible, go for 80% first instead of 100% all the time. Okay, thank you. So is there any questions from the audience, either on these three country presentations or maybe also for Gemma on the data for management part? So I'll take a few questions. So I see Dimitri, the gentleman there. So let's start with these two questions.
Thank you.
So, sorry, can you also say who you're addressing the question to?
Yes, thank you very much. It's a question to Vasif on Pakistan. So, two quick clarifications. Who is currently employing the people who are doing the data entry? Who is currently employing the people who are doing the data entry? And what arrangements are you making in your plans and strategies for the sustainability of the system so that the system runs in terms of data quality when the project ends this year?
So let's first have the other question. So
yeah, for me, it's not a question, but I have three small suggestions to Gemma about the data management. The first one is the new tools that will be launched to the country should be very simple, as you know. But the problem now the fact is that now the many countries also already used the tool that developed by WHO in Excel type. That's why it is very quietly used. That's why the new I hope the new tool will have the same frame to avoid any kind of the unnecessary the resistance from the new health workers. They don't want to see that very different kind of tools because they think it's very complicated and tiring for them. Or at least make sure that convert the data between the old one tool and the new tool should be very simple, kind of just the paste and the copy and paste. That's all kind of it. And the second one, as you know, is because for health workers, they have already the IT acumen, but they still use the very old version of the Windows, and it's not very high tech, the laptop. That's why I hope the new tool should be installed, used easily with the old version, the Windows, and the not high tech, the laptop. And the third one is regarding the language issue, because we know the target countries, we know which language they use. That's why once the new tool will be launched, I hope the kind of their English version and the French version, the Spanish version, be already ready for the health workers, accept easily to use. Yeah, that's all. My small suggestion. Thank you for your attention.
Thank you. Did I see a few more hands? Marasi and the gentleman there, and then we'll take those 4 questions and answer them.
All right. First of all, thank you to the presenters for the excellent set of presentations. My question is directed to the gentleman from India. You mentioned the term meaningful data, which I found intriguing. Meaningful data can mean 2 different things to 2 different people. What might be meaningful for me might be different for you. Can you elaborate a little bit about the process that you went through to standardize what meaningful data is for both the user and the people who are developing the system, and how then you managed to harmonize and standardize that process to make and achieve the results that you presented?
All right, and then we have one last question there.
Thank you. I've got two aspects to raise. The first one is a little bit related to data generation. This is a question from at country level technician, and I want to understand a little bit of the details. How did you go about this migration to data generation with electronic devices? How was it, the uptake by the health workers? Did you went through a phase where you had both paper-based and electronic-based, and then was it phased out? How was that experience? I'd like to hear a little bit about that, to learn from your experience. The other one is a little bit, it's about sustainability. Did you think about, once these systems are being developed, to also train people in the pre-service, not only in service, so that you can have staff that is already trained with that? So is that also in the picture? And if yes, we'd like to listen a little bit of the experience with that. Thank you.
Okay, so let's answer these questions. So we'll take it in the order that they came from. So Wasif, Gemma, Bhrigu, and the last question I missed, was that for Chathura? For Chathura. So perfect, we have a question for everybody. So Wasif.
Thank you. Actually, data is entered by the government officials, and there are more than 534 data entry points right now, but in next month it will become 650 data entry points. And the question of the sustainability. We have trained the master trainers from the government, and those master trainers are continuously giving trainings to the government officials. And second thing, we have given the responsibility of the data entry supervision to the tehsil level supervisors, instead of developing some new or parallel responsibility structure. These tehsil level data entry supervisors are mainly meant to oversee and supervising the data entry by the vaccinators. So I think that the government, the software or the server is with the government, the data entry is doing by the government, and the supervision is by the government. I think it may be sustainable.
Yes.
Will be sustainable. Thank you.
So, so you had a question about the proposed indicators and guidance. Actually, it is not a tool. It is not an IT system. It is a resource. It is a guidance about how can you improve the system that is being used for monitoring. What do you need to take into consideration? It could be that you decide to do it on a paper. It could be that you decide to call your districts and hear what is your stock levels and write it on a paper. So when we say system, it doesn't mean IT system. So it is a resource in the sense that it is proposed indicators that have been developed with WHO, with UNICEF, with the Gavi Secretariat, with BMGF, with representatives from implementing partners as well, and reviewed by countries. So in this sense, we're trying to make it as inclusive as possible so as to reflect different points of view and make it as simple as possible as well. So, for instance, even if you have DVD-MT data, for instance, already from this data that is already being collected, one can extract and use some of the indicators and visualize them as well.
Thank you for your question, and I think you're spot on. That's what I wanted to communicate, saying that it's essential to have a meaningful data, and the meaning changes from person to person, or rather from level to level or post to post. And therefore, you need to have a system flexibility where you can design and say, this is what I require at a A&M level, at a field health worker level, and this is the requirement that I have. And then you can also give that flexibility to the end user to choose the modality and the methodology and the visibility. So rather than creating standard fixed time, fixed way reports, you need to have custom-based reports, custom-based data analysis for each level, whether you want, so if you're doing it at the health worker level, you have a different kind of an output that your system is giving, and that gets reflected only to that health worker or to the group of health workers. The periodicity, the methodology, if you send an email to a health worker, it's of no point. So she needs to have that data, but that needs to be, whereas when you talk about the national level has a very different requirement. It doesn't want to know which fridge got burnt today. He just wants to know what's not performing, what's an average not performing, what's the major reason. So you need to present that data. So you need to create meaningful data at different levels so that that data, so it's basically the flexibility of using that data, presenting that data in different forms to cater the need to the.
I think it is about how we train the field staff from paper-based system to IT system. Okay. As all around the world, we also having field staff ranging from very young to very old. So in our education system, around 1990, IT education or the IT learning has been included. So now we are getting the younger generation with IT skills, but in the old generation doesn't have that skill. So we have used that situation. What we have done is we train the younger generation who are capable of juggling with the computers. So we gave the training and asked them to train the older generation very slowly. And instead, other than that, we also encourage our all health staff children to learn this system and train their parents. Those are the methods we have actually adapted.
Okay, thank you very much. I think we're running out of time again. It's always like that. Of course, there's still very interesting sessions this afternoon, as well as spots in the Innovation Cafe to talk more about any of these issues. I think that also the gentlemen are available, and as well as the lady are available for further discussion. I think we can wrap it up. I think that Brian is still wanting to introduce the sessions of this afternoon, but I want to ask for a strong applause for the presenters, please.
Thank you very much, Jan. The great learnings and information sharing for day 3 have just begun. So I'd like to be sure that you come back from lunch in plenty of time for a 1 o'clock session in the New York room for a roundtable discussion with Paul Coleraine from the World Health Organization on the use of binomial statistics, session and vial sizes to improve forecasting and stock management. I'm a data geek, so I will definitely be there. And then we have 2 more sets of interactive sessions to dig into the human resources and data questions with the support of the logistics management information systems. At 2 o'clock here in the ballroom, Maeve Magner will lead a discussion on the emerging use of visibility and analytics networks in countries and how you can apply that same type of blueprint for your context. And then back down in the New York room, there will be a multi-country panel from Uganda, Somalia, and Malawi discussing how do we strengthen supply chain leadership in countries. And then across the hallway in the Beverly Hills room, Jan Grevendonk and Gemma will continue the conversation that they started here, and how should we use immunization supply chain data for continuous improvement. And then at 3 o'clock during the coffee break at the Innovation Cafe, Wasif and I will be discussing the current country introductions and use of barcodes on vaccine packaging. And then our final set of sessions of the day begin at 4 o'clock with the role of national logistics supply chain working groups in the New York room. Simultaneously, they'll be discussing human resource capacity building using the EVM assessments as a tool. And then here back in the ballroom, there will be an expansion on the use of mobile technologies to strengthen the vaccine LMIS in Uttar Pradesh that was described briefly here by Bhrigu. All right. So as Gemma presented earlier, the on-time in-full metric is a key measure of the supply chain. So we are now on time, and I hope you will be full after lunch. So see you again at 1 o'clock.
Please, just a reminder to go down to the project gallery in the London room to check out some more detailed information on all of these topics. Thank you.
Well done, thank you all. Oh, yes. Yeah, there's two of them. At the 3 o'clock, there was only the one. I didn't mention the ones at 1 o'clock. So. What's that? You didn't want the yeah. Yeah, I know. I didn't want the competition. There's only one at 3 o'clock, but it was also sort of saying that there's actually 3 things going on at the same time.